Good evening all. We'll start today's session, and this is mainly about how to intubate a child to put on mechanical ventilation. So these days for last 5 days, we have been gone through how to ventilate, but most importantly, it's not about knowing how to ventilate, and it's equally important how to intubate. Unless you intubate a child correctly, you're not going to ventilate the child. So that's why this is the most important step for me, because at least if you intubate, you can at least do bag and tube ventilation till you can get a help from your seniors to adjust the ventilator settings to maintain the child on the ventilator. But if you don't able to intubate and a child is crashing and you're not able to get the help what you need at that time, then it will be disastrous for the child. So rather than intubating and just doing bag and mask, if you're not able to manipulate the ventilation appropriately, so that is more beneficial for the child rather than not intubating a child. So that's why I'm not going to teach you any theory classes here. So I'm just going to tell the tips how we can do a safe intubation, what are the difficult intubations we expect, and when you anticipate the difficult intubation, how you need to do the things in a correct way, so to prevent unnecessary complications during intubation. The main question for all is how many times you people seen that when you trying intubation, like the child is relatively stable still that time, like yeah, he's having respiratory distress, he's having something else. But he is maintaining his oxygenation a little better way, and his like other vital parameters are
Chair
but when you start doing intubation, they'll crash and they'll is it a common scenario you faced, or it is a very rare scenario getting a cardiac arrest during intubation? So you people never tried intubation?
Rare, sir.
Yes. So what is the percentage of chance of getting cardiac arrest? I'm not asking like an expert. Just I want to know. So how much percentage you can anticipate that this during if I do 100 times the intubation, how much times I can get a cardiac arrest? Or at least some drop in at least drop in heart rates, drop in severe hypoxia.
Every time.
Every time. Okay. Very honest answer. Some message put 2 to 3 times. That means you are expert, madam. You don't need to listen this class. Even if I do intubation after this many years, I'll get at least some sort of complication in every intubation. Even it's an active intubation, just we proceed for any shifting the child for OT or from transport when you're shifting the child to our hospital. If the activity we are doing, okay, this is kid, we have to do intubation during transport, so we'll finish up here and we'll shift. Even that kind of situations, we'll anticipate some sort of complications. But when a child came to ER in gasping or some kind of we need emergency intubation, then the complications and this chance of cardiac arrest go up. So that kind of thing, so we need to anticipate and we need to prevent. And one such technique for this emergency intubation is called rapid sequence intubation. And so these are the slides I borrowed from my colleague, Dr. Balakrishna. So this slides from him. So RSI is nothing but an airway management technique. So that produces immediate unresponsiveness by giving an induction agent, and you give muscle relaxation, and is the fastest and most effective way of controlling emergency airway. So that's what I'm telling. So in emergency room, when you have a crashing child and you don't have much time to do all other things, stabilization, something, and you want to secure the airway, then this is the technique you need to follow. It's a rapid sequence intubation, because the most important problem in these children is you don't know the fasting status of this child. So they have much risk for having vomiting and aspiration. And if you start bag and mask ventilation for them, then you are going to bloat the stomach and you are going to increase your chance for vomiting again. So these are the main disadvantage when you start intubating a child in the emergency room without knowing his fasting status. So how you can ameliorate that, we'll just see. So there are certain reflex responses when you try intubation, that is direct laryngotracheal intubation. So that is why some children will have protective airway responses like apnea, cough, laryngospasm, bronchospasm. These are the sometimes when you when you try to put it tube, your tube will not go in at any cost. So during bag and mask, state is fine, but when you start intubating, you're putting even the smallest of smallest tube will not reach the trachea. The main problem is the laryngospasm. What will be the reason for this laryngospasm? How you can ameliorate?
Muscle relaxation.
Your voice is not clear.
Muscle relaxation.
By giving muscle relaxation.
Okay. So why they getting laryngospasm? Why only a few children is? Is there any physiology for the what are the children who are more prone for laryngospasm? Is there any risk factors for this kind of children will have more amount of laryngospasm? You can anticipate it. Few examples.
Child with airway anomalies, sir.
Child with airway anomalies. Examples. Malaysia, child going for laryngospasm. Little unconvincing. They can have airway obstruction, but going for spasm is relatively. I don't think so. They can go for spasm. I'm asking about common conditions only. Inflamed airways are the most important risk factor for a laryngospasm. They will have the heightened sensitivity to your pain. So yeah, so that's what I'm telling. Infections. Now, the most common thing is that airway infections. They can the inflammatory nature of that disease will cause heightened sensitivity. And with the heightened sensitivity, they will have very strong reflex laryngospasm. So you need to anticipate this kind of things when you. So mainly we'll encode this kind of things in bronchiolitis, croup. So these are the conditions where they easily prone for laryngospasm. So apart from your say anatomical causes, but the mechanism is very different. This is most likely collapse of the airways, which is making it difficult for intubation, not this laryngospasm. So there you muscle relaxant in already like child is having laryngomalacia, tracheomalacia, and bronchomalacia. What will happen to the airway when you give muscle relaxant there? They'll open or they'll collapse further.
Collapse further, sir.
That's the main difference what I'm telling. So in child with respiratory tract infection, they are more prone for laryngospasm. So you need to give muscle relaxant. But in other conditions, you need to think twice before doing that, whether I'm able to do bag. But the most important parameter which tells you that I can give muscle relaxant for this child safely. One parameter. If that is not there, you cannot give muscle relaxant for that child. This is the one thing you need to check before you give muscle relaxant. That's a must. That is a must for anyone. If you're giving a muscle relaxant, it's the first thing you need to do before giving the injection.
ఎక్కడి నుంచి వస్తున్నారు ఎక్కడి నుంచి వస్తున్నారమ్మా మీరు?
I'm not asking anything abnormal.
లలిత్ కుమారి గారి కోసం.
You are going to do ventilation, intubation. So what is the first only thing you need to check before giving muscle relaxant? iPhone, can you mute yourself?
కూర్చోండి. పెట్టుకోవచ్చు. మా ఒకసారి ఇట్లా జరుపుతా నాకు కూర్చో.
iPhone, can you mute yourself? No answers. That means you people are giving not giving muscle relaxants. Okay, we'll have a poll. How many of you giving muscle relaxants for intubation? Say honestly. If I'm not getting the answer for this, that means that you people are not using muscle relaxant that commonly. What mean for telling what you are doing or not also so much this thing. Anyway, okay. So it is if you're not able to back, you're not able to get chest rise, you should not give muscle relaxant. That's all. The first and most important prerequisite for giving muscle relaxant is you have to get chest rise with bag and mask. If you're not able to get just the bag and mask, you need to be very careful. There are certain little indications where you can try muscle relaxant to facilitate ventilation, but in majority of the times, that is the absolute contraindication. You need to get the help. You need to get immediate help from your seniors. Then never ever give muscle relaxant and you're not able to do bag and mask properly. That's the first thing you need to learn from this class. Apart from this airway reflex, you can have. Please mute yourself. iPhone, I don't know. Hello, iPhone. Hypertension, tachycardia, severe can
Sir, host can mute some. You can mute, sir.
Host, my IT team are there, so I don't know. They can be available right now to mute them. Let me try once. So during ICP also, when you attempt this intubation without proper measures, your ICP can develop and it can cause coning. So your main aim for ventilating an ICP is to protect the child brain from the damaging effects of ICP and quickly control it. But during intubation itself, you are going to make him brain dead. Just because you are attempting an intubation during an ICP child, you can develop the ICP and it can cause the coning of the brain. So you need to be very careful when you're intubating all these children. So you need to take adequate measures, adequate pain, analgesia, muscle relaxation. So without all these things, if you're doing ventilation, and even if you're doing ventilation without neuromuscular blockade, that means you are harming the child. That's all. I can tell that simply that word. So I know it is difficult that many institutions won't follow neuromuscular blockade, but I think is the time for you people to think twice when you are doing intubation without neuromuscular blockade. So it's very painful, and it can like the procedure can cost the life of the child. So you need to have adequate sedation, analgesia, and neuromuscular blockade when you're proceeding for intubation. So there are certain indications for avoiding neuromuscular blockade. That is like one thing is the asthma intubation. So when you're doing asthma intubation, you need to allow the spontaneous activity for the child, and even there you can use short-acting muscle relaxants, not long-acting. So that's not a contraindication there also, absolutely. But many times I see people don't use neuromuscular blockers because they feel that if they couldn't be able to intubate, what's going to happen? That's the main fear. And what is the absolute contraindication? When you have an OT available, theatre is easily available, and you're anticipating anatomical or pathological difficult airway, don't attempt RSI. And you shift the child to OT, get the help from the anesthetist. They are the better persons to intubate than you trying it in your ER or PSU. And if you don't have a team which can support you in this intubation procedure, then please stop it. You have
ఉండదండి.
requisite skills for this, and is not available when you have children with a neck tumor or neck trauma or mediastinal lymphadenopathy, which is compressing the airways. These are the things where you should avoid this RSI. You need to have help from your team, surgical team or ENT team for this. And the main 4 distinct pharmacological components needed for RSI is analgesia, amnesia, muscle relaxation, and you need to block all the pathophysiological autonomic reflexes to your painful stimuli. So these are the 4 important pharmacological components you need to address. In that, analgesia, muscle relaxations is a must, and amnesia and blockade is little next level. And everyone should have an emergency intubation checklist. Whether you're doing it in the ER, whether you're doing it in the ICU, no, it's a must. So you need to have a checklist, and it should be an individual checklist. It's not like you have to stick it in the board. Every patient, when you're attempting intubation, you need to fill this checklist. You need to have this. Whether you prepare the patient well, you need to have access to all the equipment available, and you are preparing for the difficult airways, and the team is prepared for this. So these are the 4 important checklists you need to have. Like prepare the patient, you need to have absolutely vital monitoring, position the child, adequate pre-oxygenation, and you need to have good IV access. So these are the must for any child. And equipment, at least you need to have basic airway equipment like ambu bag, laryngoscopes, appropriate tubes, and most important thing I can recommend you people, all people should have is a bougie. It's a must for everyone. Don't tell that we are experts in intubating, so we don't want bougie. Even anesthetists who do daily some 3 to 4 intubations, they will have a bougie. So we are not that experts compared to anesthetists. So it's not like our heroism we need to show, but it's about the safety of the child. So always make a habit of using bougie. So it's not wrong in using a bougie. It's not that costly as well. It costs very less. So I request all of you from today onwards, if you're not using bougies regularly, try to use it. And drugs. So you need to have the drugs for RSI. You have to support the child for hemodynamics and as well. So with this, you you prepare the patient, and you get all the equipment. And you need to prepare for the difficult airway. So if you thinking that this child might have a difficult airway, then you need to have assistance from a video laryngoscopy. And if you're suspecting upper airway obstruction, you need to have a cricothyroidotomy kit as well. It can be just a needle cricothyroidotomy, or you can call for a surgeon. And most importantly, the unit should have a difficult airway trolley. So if someone is telling that this child is going to have a difficult airway, then you should not check all the things is available or not. You need to just tell the sister that bring the difficult airway trolley. So you need to be prepared for that. So you need to have like in emergency ER room, you have a crash cart like that. You need to have an airway trolley as well. So there is a same as important as your crash cart. a difficult airway trolley, because in many times in an emergency, you need to do an emergent intubation. So for that, at least you need to anticipate that the child might have any difficult airways, and you anticipate that you need to have an immediate support for you in the form of other things are needed for that. And you need to have a team for all these things, and always get a senior help. So I'm telling, that's what I learned after many years. When I'm doing PG, I'm very enthusiastic. I don't want to give chance for anyone. I try 4 times, 5 times, 10 times. It's not like you need to compromise for your learning. It's about child safety. So lastly, the mnemonic for this thing is soak me. So you need to have suction, you need to have oxygenation, you need to have airways. That could be oral, nasal airways, your laryngeal mask airway. So you need to have all the equipment ready for cricothyroidotomy, and position the child. And you need to have monitor, medication, sedatives, paralytics. And if you need to confirm that laryngoscope is that ET tube is in, you can have ETCO2. If it's not available, also fine. But bougie is a must. So if you tell me the one important thing you need to have, apart from the routine laryngoscopes, ET tubes, laryngeal mask airways, bougie. Make a habit of keeping bougie in your airway trolley. It's a must. There's no other way for that. The most important drugs for sedation, it's like ketamine, fentanyl, midazolam, propofol. I'm not going to discuss much about them. And you can better read them or the advantages and disadvantages for them. But I can tell, if you name one drug, you don't want to confuse yourself for any intubation. What the drug you can use safely. You can just close your eyes. You can tell I need this one drug. That's all. If you remember that ketamine, that is enough for us. You don't need to think about other things. Anything, any airway, any problem, any intubation, if you choose one that is ketamine, that is enough for us. And there are 3 blockading agents. That is one is succinylcholine. This was routinely used previously, but now with the risk of complications, we avoiding it. Mainly, they're going to use it in the OT. But in the routine intubations in the ER, we are avoiding them. When we have a safer agents like lucronium, where it is a very rapid acting and short acting, rapidly acting and a little long acting. When we need to go for this, or we can have lucronium also. It's a cardiostable one. The only thing is it can get a delayed action. That's the main disadvantage, you can get a risk of bradycardia, you can get a risk of hyperkalemia. So you need to avoid the child hyperkalemic children. Be careful with the children with hyperkalemia. If you anticipate AKI or child is having severe metabolic acidosis, so then better to try to avoid succinylcholine. The last thing is you prepare all the things. You pre-oxygenate. The pre-oxygenation is a must. Either you give it by simple face mask, or if the child is having some amount of like hypoxemic conditions, you can try with HFNC and NIV also. And you need to give stabilize the patient. You need pre-treatment. If the child is having hypotension, you need to give fluid bolus. So that kind of things you need to finish in next 3 minutes. Then in the 0 minute, you start the child giving drugs. You start with the sedation, then you give neuromuscular blockade, and then you need to position the child quickly in 30 seconds and visualize your you can do perform Selig maneuver also here, but now we don't perform the Selig maneuver routinely. So there are certain guidelines now that this is not that useful maneuver now. So there's only very few indications now for celiac maneuver. It's not routinely, you don't need to apply it. So that's what the current guidelines are. No need to apply routinely. It's only for very few indications. Like when child is having a full stomach, and you anticipate the child might have a vomiting, then like that. And then you need to have proof that child is become flaccid. Then you perform the intubation, confirm its placement. And then once you done the intubation, you need to immediately start the sedation. Whether you want to continue paralysis, you need to decide. But don't delay the starting of sedation post intubation. So you need to take the call immediately. So prepare, pre-oxygenate, pre-treat the underlying conditions, use the induction agents, position the child, make sure the child is flaccid, go for intubation, confirm the placement, and start the long-term sedation. So this is the rapid sequence intubation. So with this, we'll move on to the next important topic, difficult airway. So there are certain conditions, even without your anatomy of the airway is difficult, like upper airway obstruction, anatomically you are having certain problems with the airway anatomy. There are certain conditions where you can have difficult intubation, like you can land the child in cardiac arrest. Even without, you are very successful, you can put the tube in first attempt. So you are confident, you are expert in putting tubes, and you put the tube in first attempt, but if you see the monitor, child heart rate will be 0. Do you see this kind of scenarios commonly? You are expert. You just put the tube in like very fraction of seconds. But finally, what you see the monitor is cardiac arrest. You think what I did? I done everything correct. I just put the tube in first attempt. But it had collapsed. Have you seen these scenarios? It's very rare scenario. This is such a common scenario. So there is no mistake from your side to put the tube, but you not anticipated the physiological problems while putting the tube. You not corrected them. That's the main problem. So in them, there are 3 conditions. One is hypoxemia, hypotension, and severe metabolic acidosis. These are 3 common conditions. So where you can get this difficult physiological difficult airway. Why hypoxemia children has difficult physiological airway? Why they prone for more prone for cardiac arrest? What is the physiology in hypoxemia which is causing cardiac arrest? So in hypoxemia, the reserve, already we know the FRC is very less. So they won't tolerate much amount period of low oxygenation. So you doing intubation, you taking much time for intubation, and if you're not supporting providing oxygen for the child appropriately, so then they can go for low saturations leading to cardiac arrest. So you should anticipate these things, and you need to prepare for that thing. And why during hypotension, when you attempt intubation, child can have cardiac arrest? Reasons? If you don't stabilize the hemodynamics and you are attempting intubation, the child can collapse. What is the reason for this? Just think, I'm not talking anything excessively here, because we already discussed what are the adverse effects of intubation during
మార్నింగ్ ఈ డివైస్ నా ల్యాప్టాప్ కనెక్ట్ చేసి ఆన్ చేసి లాగిన్ అయింది, బాగానే ఉంది. ఇప్పుడు మళ్ళీ వచ్చాను.
worsen the hypotension. The drugs what you are giving, like if you give midazolam,
పెడితే
further.
USB not required.
Two things you need to be very careful when you're doing intubation in a hypotensive patients. And the final thing is metabolic acidosis. When you have a change in severe metabolic acidosis,
Morning.
intubation can cause cardiac arrest. So
అదే sport లో పెట్టాం.
it is 6.9, your bicarb is 5, CO2 of 15. You start intubating this, have some crash.
నేను తెస్తాను.
So you give the sedation and paramedics for this child and you induce apnea. Suddenly the CO2 still the child is breathing with the higher rates to wash out the CO2 for the metabolic acidosis. Once you stop the apnea,
పెట్టేశారు.
CO2 will I think these iPhone people, they are not interested in the class and I think they're not checking the messages also. I don't know, anyone knows these people, iPhone people? They are some PGs only. If you're not interested, please log out. And this severe metabolic acidosis is one condition you need to be very careful when intubating this kind of children. So never rush for intubation. So it's going to cause the cardiac arrest. So you need to anticipate this and you need to prevent. So the next question is how you are going to prevent this cardiac arrest during intubation when the child is having these three conditions. We'll start with the first condition, hypoxemia. How you are going to prevent cardiac arrest? What are steps you're going to, precautions you're going to take?
Pre-oxygenation.
No, pre-oxygenation will not be enough. You have a severe ARDS child. How you're going to improve oxygenation by giving pre-oxygenation? Yeah, one pre-oxygenation is beneficial for many other conditions. But when you're talking about severe hypoxemic children, pre-oxygenation by just giving oxygen is not enough. You need to have something else here. I already told in the RSI, just you need to retell it. What you need in ARDS is oxygen, you need something else.
With pressure.
Yeah, that's so always you need to see what is the underlying physiology, what I need to do for the correcting that physiology. So how to provide pressures here? Bag and mask. Okay. Can anyone, everyone agree with I can provide PEEP by giving bag and mask? By your ambu bag. I'm talking about ambu bag. So with ambu bag, can I provide PEEP? Then how is the bag and mask going to help for this child? So here, yes sir. Ambu bag will give PEEP. You need to go back and read your basics again. Just remember this.
Bag with brain circuit in this size.
Ambu bag will never provide PEEP. It is going to provide only PIP, and I already mentioned this in many classes. The button and the pop-up valve you're going to press is to increase PIP, not to provide PEEP. There are certain separate valves which are available that you need to keep to the ambu bag. This is PEEP valve. That's called PEEP valve. You can just Google it and see. So you need to fix it between the connection to the ET2. It should be between ET2 and the ambu bag. So you can adjust the PEEP there. So that's the PEEP valve. Or if you don't have that valve, don't worry. You can have a band circuit, a simple band circuit which is having a valve, so that you can adjust how much of the PEEP you need to keep in that. So that's the one way you can. Or other thing, simple thing is you can provide it by through your HFNC or NIV. Just put the nasal mask, nasal NIV, and even on that you can intubate. So even without disconnecting NIV, you can intubate a child straight away by just following the RSI principles. So many times in ARDS, we'll try NIV first, and if the child is already an NIV, when you want to proceed for intubation, I don't disconnect NIV. I'll just go with the ventilation, even the child is on an NIV. So I don't do bag and mask for them. I just put them on the NIV settings with high PEEP and optimal PIP. So then, and with the same thing, it will not difficult. Only when the child is on Voro nasal mask, then it will be difficult for you to ventilate. But if your child is a nasal mask only, then it is easier for to intubate this child, even keeping that mask in situ. So these are the certain things you need to do, and most importantly, you need to get an expert in the place because they will not tolerate apnea. They cannot tolerate apnea, so they quickly go down. The SATs will quickly go down, and you need to be very much expert in putting tubes for this kind of children. So always try to get a help. Even it's normal intubation, normal intubation, it is safer to keep an expert or helping hand with you. So you do the intubation, but always keep a person who can help you. So that's what I'm telling. We should never do things for making us happy, like to show I can expert, I can intubate anyone. It's not like that. You know, we all can intubate any person, but that particular day, that's not your day. It can happen any day. So that is what I learned with my experiences. So I don't want you people to learn same way. That's why I'm telling. Never think that if you need to get help, that means they feel that okay, I don't do anything. It's not like that. It's okay if they feel like that, it's fine. But at last, you are going to save a child. So think in that way. So never ever think that if I call a help like that, I am they think in that way. So it's not like that. So don't think in that way. So always try to get a help. Even that could be junior, fine. Don't think that juniors cannot help you. Even if I'm not able to intubate, my juniors can intubate. It's that your bad day, that's all. So you should not think like that. So please change your perspective here. It is not about intubations in any procedure. It's not that you alone can do, others cannot do. That's what I'm telling. If you're not able to do, others can easily do because that's your bad day, that's all. So in hypotension, how to correct? How to prevent cardiac arrest in hypotension? So you need to give fluid bolus. Can you give fluid bolus for all children with shock? All children with hypotension, can you give fluid bolus? The next question. Huh? Is it correct or wrong? Can you give fluid bolus for all children in hypotension, irrespective of cause?
Inotrope support, but
No, I just answer my question.
yes, sir, we can take.
Fluid bolus for
Meanwhile,
all children in hypotension, irrespective of the cause.
yes, sir, trial of bolus can be given.
Trial of bolus. Okay.
Meanwhile, we prepare
Same
inotrope
amount, same time, or different amount, different time.
different amount depending on
Example? Can you give me one example where you don't want to give fluid bolus?
in cardiac shock.
You know the physiology of cardiogenic shock is LV dysfunction. Then why you want to try to give fluid bolus there? You can safely do start an infusion of inotrope. Then why you want to give fluid bolus and complicated things? Once you give fluid bolus, already there is a pulmonary edema. You're going to worsen the pulmonary edema. It's going to cause more physiological difficulties for you. So never ever try to give fluid bolus for a cardiogenic shock child. You need to anticipate. If you don't need to confirm it. That's what I'm telling you. You don't need to confirm it. If you anticipate, it could be a cardiogenic shock. Try to avoid fluid bolus. go for an early inotrope. So that is going to prevent your cardiac arrest. If you are not anticipating cardiac shock, fine, you can give fluid bolus, you can start NARAD, it's fine. But if you anticipate it's a cardiac shock, don't give fluid bolus, just start adrenaline. So this is what you need to think before you starting intubation, whether I have a high oxygen deficit, whether I have a high ventilation deficit, whether I have a high perfusion deficit. High ventilation deficit is pH less than 7.1, and hypoxemic even with a high flow O2 like NRM. Your cell is an NRM, and even if the cell is hypoxic, then you need to think that this is something else. It is not just a low oxygen, it is your ARDS lung kind of thing. And high perfusion deficit is mainly shock. So relatively well, you can go for intubation straight away. Relatively sick children, you cannot avoid intubation. Certainly, you cannot avoid intubation, but you need to optimize them before intubation. You need to start resuscitating them before you intubate. That's the most important thing. Even a child with saturations around 70, 80, they can tolerate little bit of hypoxia for 10 to 15 minutes. But if you don't give fluid bolus by push and pull, and if you don't start an inotrope, you start intubating them, they can go for cardiac arrest. That's what I'm telling. Your very concern is over, the child is hypoxic, saturation 80, I want to intubate. But if you don't think that this child is having hypotension also, and if I don't correct this hypotension during intubation, this child can land up in cardiac arrest. So that is more problematic for that child than the hypoxia of 80 saturations. So this is one point I want to stress again and again with this class. So you need to anticipate there is a physiological difficult airway. Don't worry about saturations of 85, 86. They can easily tolerate that for few minutes to hours, but they cannot tolerate sudden drop in BP, sudden drop in pH, or sudden drop in saturations when you hurriedly do the intubation. Is it clear for everyone what I'm talking? Are any doubts or any confusion here? There are only three conditions. One is oxygen deficit, ventilation deficit, perfusion deficit. So you need to anticipate these three conditions during intubation. You need to resuscitate them before intubation. You need to start resuscitating them. You cannot do intubation. You cannot proceed to intubation just ignoring all these things. So from today onwards, you need to make a checklist, and every child you're intubating, you need to think that whether they are in these three categories: high oxygen deficit, high ventilation deficit, high perfusion deficit. So then only once you start correcting these deficits, and once you prepare yourself, so I need to do all these things before intubation or during intubation or after intubation. So these are three has to go hand in hand. So then only you need to proceed for intubation. No doubts? Can you move on?
Yes, sir.
This is a case scenario, so I'm not going to go to the case scenario again. So one thing is, when you're intubating a metabolic acidosis child, you need to support them to the extent what they're breathing. You cannot give physiological rates for that child. If you're intubating and severe metabolic acidosis child and child is breathing at a rate of 60, when you start bag and mask ventilation, what is the rate you have to provide for them? Is a physiological rate of 30 or it's a 60 what a child is breathing? No answer. Child is breathing at a rate of 60 to maintain CO2 to maintain pH. And you are trying, you given sedation and a paralytic, and you started bag and mask. Whether you follow the same child rate or you want to go for normal physiological rates. That's what my question here is.
Same rate.
Hyperventilate.
High.
That is the one thing you need to remember. So you need to match the patient rates and volumes. Even post intubation, you need to match it. If you don't match it, you're going to increase the CO2. Increase in CO2 is going to drop the pH. And you can try to give rescue bicarbs here. This is the one classic indications for giving bicarbonate. So you can give 1 to 2 ml per kg of the bicarbs before intubation, so they can just increase your pH a little bit. So you can get some extra cushion for apnea. And you need to put the tube very quickly. You cannot delay the apneic period. If you delay the apneic period, then the child can crash. So these are the two important things. One is matching the rate of the patient rate, and second thing is rescue bicarb. So two important things you need to do, and you need to get an expert who can put the tube in seconds. So with this, difficult airway, physiological difficult airway. So when you need to go for anatomical difficult airway, there are certain scoring systems and certain scales you need to do. One is the Lehane scale, one is the Malampati scoring. I'm not going to talk about this. If you apply this scale and you found that this child might have a difficult, anatomically difficult airway, you need to get the expert. That's all. If you think that there is an anatomical difficult airway, don't attempt intubation by yourself. Please call an expert. So these are the facial features which will tell you that this child might have an anatomical difficult airway. These are the predictors. So starting with the teeth, alignment, mandible, depending on the degree of mouth opening, how is the palate, how is the submandibular space, thyromental distance, length of neck, neck size, head and neck range of motion. So some of the children will have contractures. They'll have spine contraction, like a severe CP child. So they will not able to flex the head at all. So that kind of children, you cannot do smooth intubation. So you need to anticipate difficult intubation. Once you anticipate difficult intubation, you need to call for help. Either it could be anesthetic, it could be surgeon, it could be ENT surgeon. So these are the predictors for difficult airway. And if you're able to see one thing in the child, then please get an help. Don't attempt intubation if the child is little stable. If the child is unstable, child is collapsing, then it's fine. I'm not going to tell you should not do intubation when child is already collapsing, or child is having bradycardia and child is collapsing, like in birth of cardiac arrest. So you do other things first, stabilize the child. Meanwhile, you call for the help. If it's absolutely indicated to put the tube, you put the tube. But if it's not absolutely indicated, then you can manage with bag and mask. You start CPR if needed. So that are things you can do rather than wasting your time on intubating this kind of children. But if the child is really stable and if you can able to delay intubation, please delay it until you get a proper help. That's one thing you people has to get it from this class. And these are the questions you need to ask when you are proceeding for these things. So this child have potential difficult airway. You take history examination, and if you found that, get the help. And you think that this child can be maintained with the bag and mask device, then safely you can delay the ventilation. If you feel that you have difficulty in direct laryngoscopy, you can get help for others to assess the airway. So if you're not able to do bag and mask ventilation, what you're going to do? So the child is having low saturation, child is collapsing, and you need to start some sort of positive pressure ventilation. And the immediate rescue for you is bag and mask ventilation. And if you're not able to do bag and mask ventilation, what you can do? What are the routine things you need to do when you're not able to get adequate chest rise and you're not able to pick up the saturations and bag and mask ventilation? Is there any memory?
MR SOPA. MR SOPA. We'll see MR SOPA.
MR SOPA. So what is MR SOPA? Can anyone elaborate it? What is MR SOPA?
M for mask. M for mask, proper positioning of mask cell.
Okay.
R for repositioning of airway.
Okay.
S, suction.
How to reposition the airway? 2 steps how to reposition the airway.
Head till chin lift.
Chain lift, sir.
Yeah. Okay. So you need to make the airway straight. That is what the final answer is. So that what you're going to do it by head tilt and chin lift. So you need to put the tongue out, and you need to align the airway. So you can just put in a shoulder roll. The sniffing position is what the position is. Sniffing position, you need to make sure that you are in the sniffing position so that your airway is aligned. So that's the repositioning the airway. So next, MR over. S for
Suction, sir.
action. So to relieve the obstruction, airway obstruction, and O for
Open mouth.
Open the mouth.
Or lift this one.
P for
Increasing the pressure, sir.
increase in the pressure. A.
Alternate airway.
Can you name some few alternate airways?
Laryngeal mask.
Intubation or LMA
Yeah, laryngeal mask airway.
or ED2.
So when you did MR so far and last year, you need to decide what you need to go for. So when you have an upper airway obstruction, you can try this oral airway. If you're not able to control the tongue, you can put in oral airway and you can start bag and mask. And sometimes we feel some children having nasal blocks like clots and all, and there you can go for nasopharyngeal airway, and then you can ventilate them. Ventilators, you can just provide them oxygen, or you don't want to do bag and mask, you can do on that. So before we are going for intubation directly, when you want to optimize the things, that's what I'm telling. And if you know upper airway obstruction was there, and you need to anticipate laryngospasm or bronchospasm when you're not able to get adequate chest rate. So you need to adjust your analgesics and neuromuscular agents here. So finally, you prepared yourself for intubation. You tried intubation, but you couldn't able to do. What you need to do? You tried intubation. So all the things are optimized. You've done all the optimization things, everything, and you couldn't able to secure 82, even after repeated attempts. Even after repeated attempts. So what are the other things you can do?
Call for help, sir.
You can at every step. That's what I'm telling. At every step, once you decide I'm going to intubate, you need to call for help. That could be your junior, senior, or you need to call for the expert. That depends on your anticipation of difficult airway. So you need to anticipate. You anticipate a difficult airway. Depending on the degree of anticipation of severity, you need to call for what help you need. But sometimes you attempt intubation, but you're not able to anticipate that thing. And during intubation, you found a difficult airway. You're not able to intubate. So this is what you most common scenario is going to happen. So there you don't get adequate help immediately. So they need to decide what to be done for this at this particular moment. You've given drugs, analgesics, neuromuscular blockades, and you start intubation. If you don't able to bag, you should not give neuromuscular blockade. That's what I'm telling again. So if you're not able to bag, please try to maintain child some sort of alternate airways other than intubation. If you're able to do bag and mask, then you can try giving neuromuscular blockades. And you give neuromuscular blockade and you're not able to intubate, then what you have to do? You give a neuromuscular blockade, you can easily do bag and mask, but you're not able to put the tube. So what you have to do? Is there any options you left with? You can call for help. Even for them, it would be difficult. So what are the options? What they have? If you anticipated, fine. If you're not anticipated, only this problem is. No options. You leave the child to die.
Okay.
Until you get a help, what you can do, man? You're not able to intubate. You given parameter.
Continue bag and mask till it helps.
That's all. Please continue bag and mask. Don't stress yourself by repeated intubations. By attempting repeated intubation, if you're not able to put the tube in second or third attempt, you're never going to put it. Mark my word. So rather than repeatedly making the child going for hypoxic episodes, if you're able to do bag and mask easily, you can do bag and mask for hours. I done my fellowship in child trust, and we do all the procedures in the OT, like minor procedures like bone marrow biopsies, wound dressings, and your osteomyelitis dressings, kind of things. All these things, small procedures, which will last only for 10 to 15 minutes, we'll not intubate that child. So we're going to sedate them, give them a lot amount of propofol, and we'll keep them on bag and mask ventilation. Even if they don't have any efforts, we'll just keep them on bag and mask ventilation, and we'll get out of them on the anesthesia. And because the propofol start acting, they'll come out very easily, quickly. And once the procedure is over, we straight away within 2 to 3 minutes they'll come out of that. So for 10 to 15 minutes procedures, we'll never intubate. So that's what I'm telling. So you can easily manage the child bag and mask until you get an support help for that. So don't keep on repeatedly attempting intubations. That is a very harmful for the child. So rather than you decide that after second or third attempt, I couldn't able to do, so call for help, wait for it. Meanwhile, you can just keep them on bag and mask ventilation. You can keep them hours together. That's what I'm telling. That only thing is you need to help for that. Someone has to do the bagging. You need to hold the mask. That's all. Because your hands muscles will get fatigued. And one more simple option you have is supraglottic airway. So this is the other thing you need to keep it in your ER or PICU. So it is a very simple thing. If you know how to put supraglottic airway, and it is a very simple thing, and you're not able to intubate, you can at least try the supraglottic airway. And some majority of the conditions, you can easily maintain them on supraglottic airway. Very few conditions where you're going to fail that, but in many conditions, if you're able to do bag and mask, you can easily maintain them on supraglottic airway. And in the recent advanced supraglottic airways, they can have an intubating SGA. They can have an holes for NG tube and also for AT tube. So they'll just they go and cover the glottis, and once you put the tube through them, it directly going to enter that airway. So that kind of SGs are available. So if you have a high load for intubations in your unit, I think I'm going to suggest these two things to be kept there. And finally, you can have bronchoscopy, and sometimes we'll have very small like guide weights, what you're going to use for. So for central line research, you know the Seldinger's technique. You're going to put the guide weight. That kind of things are available. It's similar to bougie action only, but bougies may not go in. But if you have a small that catheter kind of thing, they'll have. It's like a guide weight. So you can insert them, and through that you can railroad the ET tube, depending on the size, what they can negotiate it. So that times you can that things can help you better. And finally, you cannot do bag and mask. You cannot intubate. That's the scenario. So child is on the verge of collapse, and you cannot intubate and you cannot ventilate. You're given all the things. So you given neuromuscular blockade, you given everything, and you cannot ventilate, you cannot intubate. If you anticipate the problem, you should not give bag and mask. But you given if you answer the problem, you should not give neuromuscular blockade. But you not anticipate the problem, you just given neuromuscular blockade, and then you realize that problem. You couldn't be able to ventilate this child with bag and mask also. So now what do you have to do? to call for help. But what is one thing you can do for life saving here? Tracheostomy. How are you going to do tracheostomy when you don't have a call for help? The answer is tracheostomy only. But how to do you are not expert in doing tracheostomy. You need to get the help for that. Is there any easy way to do tracheostomy by yourself?
Cricothyroid.
So you need to get a needle cricothyroidotomy, and the easiest way to do needle cricothyroidotomy, what we practice is you get a 14 gauge IV cannula. It's IV cannula. I'm not telling any mistake here. 14 gauge IV cannula. What is the color of 14 gauge IV cannula? Yeah, what is the color of 14 gauge IV cannula? It's orange color. So just you need to keep that thing, and you need to have a connector to connect bag and mask for that. What could be that connector? You cannot directly connect bag to that, right? That 14 gauge cannula. What you can connect to connect the bag and ambu bag to that?
ET tube connector.
Which size of ET tube can fit to the
3.5.
Exactly. So you need to disconnect the blue connector from the ET tube of 3.5 size. It can absolutely fit to the 14 gauge cannula. And with that, you can do bag and you can call it like bag and tube ventilation only. So you should all know where the cricoid membrane is. It's just below the your most prominent point, that is the thyroid cartilage. So just below that, you need to feel that soft one. You need to insert your IV cannula straight away, perpendicularly. Take out the needle, just advance it further, connect the 3.5 ET connector. You do bag and mask. Don't give high volumes. So you need to give low volume just to keep the child survive. That's all. What is the problem if you give high volumes? What will happen? What will happen if you give high volumes? What is the size of this 14 gauge cannula? Is it at least near to your 2.5 size tube? No one's seen 14 gauge cannula. Okay, fine. It will not be even the size of your 2.5 size tube. So you are ventilating a 10-year-old child with 2.5 tube. What will happen? You are ventilating a 10-year-old child with a 2.5 tube. What will happen? And there's no leak at all. You can push the air in, but what is the problem here? You can push the air in. You need to give more pressure. That's all. Inspiration is not a problem. What is the problem here? With a smaller airway. So you cannot get the air out of the lung. You cannot get the air out of the lung. You have a very smallest of the sided airway in the place, and expiration is passive. Inspiration is active. You can push how much of the air in, but you cannot get the air out. So be careful when you ventilating through this cricothyroidotomy needle. So you need to give very low volumes, and you need to give more time for expiration, less rate, just to keep the child survive. That's all. You don't want to normalize the O2 and CO2. It's just you need to maintain them, not to go for cardiac arrest. That's all. If you do that thing, you call for the help, you can make the child survive. And if you don't have all these options, then that's the fate of the child. That's all. But the three most important things you need to keep if you are doing ventilation in your unit is, I finished it here. From today onwards, you need to have three most important things in your unit. But if you are doing ventilation, intubation, but even others, even in the secondary second tier centers, you need to have these three things must. You don't know when you're going to get a difficult airway change. When you when you need to intubate, but if you feel that it is not safe for you to intubate in a peripheral sector, where the attendants can go gaga and they can do all these things. You can avoid that thing there. But when you are in tertiary care center and you are the only people available to do mechanical intubation there, 3 most important things you need to have. Can anyone label that? First thing is
Boji, sir.
OG.
Rugi, sir.
Second thing, supraglottic airway. Third thing, 14 gauge IV cannula, ED2. That's all. Rest of all things you will have. When if you're practicing intubation, if you're doing intubation, you routinely have all the things. But what the things you don't keep with you is Buji, supraglottic airway, and emergency needle cricothyroidotomy set. This is a must. The 14 gauge cannula and this 3.5 SI GT tube is a must when your unit is practicing intubation. I think I'm clear on this. So if you don't have these 3 things, please stress your unit to get this. If there are no doubts, we'll end this. And I have a request from Vijayalakshmi ma'am that we need to have one more session talking few basic things like when to choose which mode and how to give nebulizations on ventilator. So this kind of things I think I will cover in either tomorrow or day after tomorrow. So I will let you know, people. If you don't have any doubts, we'll end this session here.